Nevada Virtual Sickle Cell Symposium. We're excited to have you join us today. My name is Cheryl Wilson Kennedy, and I am the Public Relations Director and a board member for the hosting community-based organization of the day called Bridging the Gap, Adult Sickle Cell Foundation of Nevada. I'll be your host and moderator of events. Our hope is that you'll leave today armed with a plethora of information and a renewed sense of hope for sickle cell. There are things being done for the sickle cell community, and we thank God for that. In just a moment, I'll introduce you to someone very special who can tell you more about the organization, Bridging the Gap, Adult Sickle Cell Foundation of Nevada, how it came to be, and what we do for the community. The 2020 Nevada Sickle Cell Symposium theme is Sickle Cell Unite, Bridging the Gap, like our organization. It's a fitting thing because we have the community-based organizations in Las Vegas collaborating to bring you this phenomenal forum. Not only do we have Bridging the Gap Adult Sickle Cell Foundation of Nevada, but we also have Sickle Not Broken Foundation of Nevada, Sickle Cell Center of Nevada, part of the Hemostasis and Thrombosis Center of Nevada, and DreamSickle Kids. I'd like to thank each and every one of them for endeavoring to put such a worthy event together. I'd also like to thank all the sponsors for our event. They include GBT, Novartis, Terumo BCT, Bluebird Bio, Immunize Nevada, New Leaf Family Services and Wellness, Everyday Life, Dash for Donors, and Sickle Cell Empowerment Team, part of the Nevada Childhood Cancer Foundation. Some of you know that as NVCCF. I'd like to encourage you to please visit the virtual exhibitor booths in the exhibitor hall while you still have a chance, but please do that after the speakers have had an opportunity to complete their presentations. The exhibitors will be available until 2:30 today, but of course the information will remain on the virtual site for a couple of days. Now, it is a privilege and an honor to introduce to some and present to others a woman with great character and conviction, a woman who I have known and had the pleasure of knowing from my youth as we have journeyed through life together, a woman who came to know and live with the challenges, the obstacles, and the release of sickle cell disease through an unwavering care and concern for her two sickle cell warriors, Sandra Nicole and Xavier. She's passionate and motivated to see the accomplishments and ultimately an end to the disease itself. Again, it is with great pleasure that I present to you Miss Pamela White, founder and CEO of Bridging the Gap, Adult Sickle Cell Foundation of Nevada.
Hi, everyone. Thank you. Thank you so much, Cheryl. Cheryl and I have been friends since I think I was in the 7th grade. And for us to be on this journey together is such a pleasure for me. My name is Pamela White. I'm best known as Pam. I am the founder and CEO of Bridging the Gap Adult Sickle Cell Foundation. I've been involved with sickle cell disease for over 40 years. Because as I said, I have a daughter who's 41, my son is 21. And as the results of their journeys, I've had the opportunity to work with Dr. Rashid, who is a part of the Sickle Cell Center. She has started the Sickle Cell Center here in Nevada, and we're so proud of her for that. And I've worked with Nevada Childhood Cancer Foundation. I started working with Nevada Childhood Cancer Foundation in 2011. And I was awarded an opportunity to go to a symposium in California when I first met this dynamic Mary Brown. I know some of you may know of her. I met her and her team, and they introduced me to a lot of things that was going on in the sickle cell community that I was not aware of. They even told me about the Sickle Cell Disease Association of America in Baltimore, where I was awarded the opportunity to go to one of their conventions. While there, my eyes were opened. It was open to the complex world of sickle cell disease. I was able to meet a lot of people. I learned about different organizations and resources and the opportunities available to make me a better advocate that I had been. When I returned from that trip in Baltimore, I went back to NVCCF and I said, hey, we have to do some things. So we had a walkathon and our first symposium. So we did that. I worked with them for about 3 years. We had our walkathons and we had our symposiums. We even participated in the Martin Luther King parade. That was in 2013, something that Sickle Cell had not done. It was a pleasure. There were people at the parade that cheered us on. There was a lot of Sickle Cell warriors there. So that was a lot of fun. Lynetta knows a lot of this. She was there with me. And although I've worked for and along with our other organizations here in Las Vegas, I felt that there was a void that needed to be filled to address the health disparities, especially for adults. Because I realized that through my journey with my son and my daughter, that the kiddos were taken care of, and they were living longer. So since this is not a childhood disease, this is a lifelong disease. So I found that the adults that were dealing with battles with health disparities was not being addressed, did not have the advocates that were needed. So I decided that is when I knew that I had to start my organization. And I started it a few years ago. I am committed and determined to see sickle cell disease, its challenges, and all the associated health disparities, if not eliminated, at least lessened. I want to see that the sickle cell patients, as they go through life, that they will live a better quality of life, that they will be empowered and educated, that they will realize that they're not in this thing alone. And I want them to be able to see past the pain, to dream past the disease, and to move forward in spite of. Now, some of the things that we have done as a community-based organization, along with others, is a blood drive. Lynetta, Sickle Not Broken, we were all together with that one. Things that we've done in the community was the food bank. We've given out food to the communities, and other things that we've done together was that the CBOs here with Sickle Not Broken and DreamSickle with Dr. Rashid, and because of Senator Dina Neal, we were able to pass our first sickle cell bill in Nevada. We, the CBOs, are also working on a Nevada state plan. Some of the things that we have done as a community, as an organization, we had our first Christmas event that was just extraordinary. There's Dr. Rashid. She was so helpful. She was even serving food, you guys. We also had our first scholarship program with a youth that Lynetta brought to my attention. That's him and his mom. So Lynetta, I thank you. We now have a scholarship program going on. And we have done, this is a part of our support group that I am so proud of. We have like 20 members and they're multi-stated. We have people in Florida, Virginia, Maryland, that's a part of our support group. And I'm so proud of this support group. We have become like a family within this group. We also have now we're in collaboration with the Health Plan of Nevada. I know that they'll be in collaboration with the other sickle cell, with the others. So, but here she sent me a thing saying that she's in collaboration with us. And so that's with Health Plan of Nevada, helping the adults that they know of that need the assistance with insurance. So I thank you. I thank you for listening to me, and we are looking forward to what we have to offer to you today. Thank you again. It's back to you, Cheryl.
Our first speaker of the day is going to be Dr. Nick Rashid. Her topic's going to be Pain Management 101. Dr. Nick Rashid is a board-certified pediatric hematologist, oncologist, She's the medical director of Sickle Cell of Nevada at Hemostasis and Thrombosis Center of Nevada. She's a hemoglobinopathy consultant for Nevada's newborn screening program, the primary investigator for the Pacific Sickle Cell Regional Collaborative Sub-Award Grant for Nevada, and a member of Nevada's Rare Disease Advisory Council. With her extensive experience, Dr. Rashid will be speaking to us about sickle cell pain. You're on, Doctor.
Thank you, Cheryl, for that introduction.
Yeah.
All right, so I'm sure you guys are tired of listening to me. It's every day that I've given a talk. But today is important because we're going to talk a little bit about pain and pain management. And hopefully we'll have some healthcare professionals as well listening in, because these are mainly targeted for them. Let's see if I can move my slides. All right. So sickle cell disease and pain. Pain is often called crisis in a person living with sickle cell disease because of their abrupt onset. And the acute episodes of pain are the most common complications that a patient with sickle cell disease experience. So on average, a patient with sickle cell disease has about 3 admissions to the ER or hospital per year. Majority of this is secondary to pain. And these admissions generate about 70,000 ER visits and nearly as many hospital admissions per year at an annual cost of over $1 billion in the United States. Apart from the economic concern, sickle cell disease also cause acute pain episodes are associated with end organ damage and mortality. About 22% of deaths in patients with sickle cell disease occur during an acute pain episode. And a higher rate of acute pain are a risk factor for death. Oops. Sorry, some technical issues. Okay, the different type of pain that our patients with sickle cell disease experience. So like any other patients, you can get acute pain from post-op. So people living with sickle cell disease do undergo a few more surgeries, such as cholecystectomy. They can have trauma, like a motor vehicle accident. They can get inflammation from other causes. And of course, the main cause is vaso-occlusive crisis. But apart from acute pain, they also suffer frequently from chronic pain. And the emergence of chronic pain usually occurs with increasing age. Young children don't usually suffer from chronic pain, but it does become more frequently as they get older. An estimated 30 to 40% of adolescents and adults suffer from chronic pain. And in order to understand how to treat pain or why pain occurs, we have to understand what happens in someone who has sickle cell disease. So basically the pathophysiology of sickle cell disease. You've heard this every day now for the last 3 days during the symposium. Sickle cell disease is an inherited disorder that results in an abnormal protein called hemoglobin S. And it's the hemoglobin S, usually hemoglobin occurs or exists as globular round proteins inside the red blood cell. But in certain conditions, especially when there's low level of oxygen in the red cells, these hemoglobin S protein then sticks together, causing what's called polymerization, where it forms these long polymers or polymer bundles when oxygen level is low. And this is what results in the abnormal shape or that sickling shape of the red blood cell. This process also causes red blood cell to break apart more easily, or a medical term called hemolysis. And this is what also causes the anemia. So the sickling or this abnormal shaped red cell causes the red cell to become more rigid, less flexible, and also increases its stickiness. And this is what causes vaso-occlusion within the blood vessels. The hemolysis portion then, because of the breakdown of red cells, it releases a protein inside the red cell called heme. Heme is the iron part of the protein. And heme is actually very toxic to the blood vessels inside our body. So with the vaso-occlusion and obstruction of blood flow, this then causes decreased oxygen delivery to the organ or tissue. And then that can cause tissue damage, which then causes this activation of inflammation, which we term sterile inflammation. It's not due to inflammation from infection, but it's inflammation from tissue damage. And this cycle here is caused by a term we call ischemic reperfusion injury. So blood oxygen level drops in that tissue. Then when blood flow returns with oxygen, that sudden increase in oxygen reperfusion actually can cause more damage to the tissue at that time. At the same time, the increased heme that's released into the surrounding tissue causes inflammation as well. And this cycle here of the vaso-occlusion and hemolysis and recurrent acute inflammation, this leads to progressive small and large cell damage and scarring. And this is important because it explains why as patients with sickle cell grows older, they have more problems with tissue damage, organ damage, and pain. And so when we look at the proposed mechanism of acute and chronic pain in sickle cell disease, as we can see here in a child, the severe episodes of vaso-occlusion, so this is where it peaks here, where it reaches a threshold where they experience pain, then they say pain is perceived. So this can be triggered by stress, weather, we say the cold can sometimes trigger pain, infection, so that's why we say it's important to protect them from infection, and then increase activity with exertion or dehydration. Most of the time in children, the pain is focal, and then it comes and goes, right? You don't suffer from pain all the time, and they only perceive pain when it's severe. But over time, this repeated vaso-occlusion and tissue injury that's occurring, inflammation that's ongoing through their lifetime, this promotes a process whereby now as an adolescent and adult, the patient with sickle cell disease suffers from something called peripheral sensitization and central sensitization of pain. And this is where instead of just focal acute pain, they're having more sensitivity and the pain becomes more generalized, more chronic, and sometimes pain that's normally doesn't provoke severe, or stimulus that doesn't normally provoke severe pain, they perceive it as very painful. And sometimes the chronic pain modulators are not usually the same as the acute pain triggers. And these modulators are, for example, stress, depression, because of what they've gone through with the on and off pain that they've suffered, anxiety, similar to post-traumatic stress syndrome. I have a patient who, when he has acute pain, he is so anxious from it that the pain becomes more severe because of the anxiety that he suffers through it. And then, of course, through all this, sleep disorder. A lot of our patients don't sleep very well because of anxiety and depression, and also concern of feeling pain. So in further in trying to understand what our patients go through, especially adult patients, back in 2008, a study was published whereby the group headed by Smith et al. Conducted a prospective study that was published. And in this study, they examined the prevalence of self-reported pain and the relationship among pain, crisis, and the utilization of services in adult patients with sickle cell disease. So basically, they looked at over 1,000 patients, and these patients completed a daily diary for up to 6 months, recording their maximum pain on a scale of 0 to 9, whether they were in crisis, so those are the crisis days, and whether they used hospital emergency or an unscheduled visit to their clinic. So that's what utilization means. They actually utilize a service for their pain. So the result that they saw was that about 55%, so more than 50% of patients, looking at 31,000 analyzed patient days, lived in pain. So that's a big amount. That's a big number there. Now, of those, the patients that actually utilize services was only the tip of the iceberg, 3.5%. The rest of them actually lived with pain, whether in crisis or chronic pain that they didn't call a crisis. Was more than 40% of those patients. So only the tip of the iceberg actually came to the doctors or went to the ER for pain management. And that's an astounding number if you think about it. But despite that, the stigma of sickle cell patient as drug seekers or patients with addiction was prevalent among healthcare providers. And so back in, this article was published in Pain Medicine in 2016, where they wanted to see why and address this frequent perception of patient with sickle cell disease and opioid pain relief abuse. And so they reviewed, this group reviewed the CDC data over several years. Let me see if I can bring this up. Okay. From 1999 to 2013, and what they looked at was the number of patients, the number of patient death related to opioid pain reliever in the total number of patients and how many patients were actually sickle cell disease patients. And what they found was the number of patients with sickle cell disease who died from opioid pain relievers related causes was significantly less than those patients with the non-sickle cell disease patients. So if you look at this number, although over the years, non-sickle cell disease patient death related to opioid pain reliever abuse was growing, however, in the patients with sickle cell disease, it kind of stayed relatively the same, and the total number was significantly less than what healthcare providers were thinking. And when they did a survey, 63% of nurses believe that patients with sickle cell disease were opioid abusers, and that 30% were concerned about giving patients with sickle cell disease high doses of opioids. A study done by Dr. Shapiro et al. Found that 53% of emergency room physicians and 23% of hematologists surveyed thought that more than 20% of patients with sickle cell disease were drug addicts, which was significantly higher than what was reported here. So that's a problem, and that's what been the struggle in trying to make sure that our patients get the care that they need in controlling their pain. So I'm going to go over some available guidelines. I actually reviewed 2 national guidelines, which was by the NIH, or the National Heart, Lung, and Blood Institute. This was published in 2014. And more recently by the American Society of Hematology, which was their 2020 guidelines for sickle cell disease management of acute and chronic pain. So first of all, when we talk about management of pain, of course, we have to talk about the overall health of the patient. So management of pain in sickle cell disease must include healthy lifestyle. We have to encourage exercise. Remember, it's not just a red blood cell disorder, it's a vascular disorder as well. And so the more we move our muscles and we exercise, then the blood flow is healthier. Keep a healthy and well-balanced diet. These can be trigger of crisis. Maintain a healthy sleep routine. We know infections can trigger a crisis, so avoidance and protection from infection. Make sure your vaccinations are up to date. In children, make sure their penicillin prophylaxis is compliant. And then, of course, optimization of sickle cell disease management is a priority. So avoidance or prevention is better than treating the pain. For a long time now, hydroxyurea has been the gold standard in management of sickle cell anemia. And if this is not something that our patients can tolerate, yesterday you heard of newer treatment that's available now in most adults, for most adults. Endari or L-glutamine, voxelotor or Oxbryta, and crizanlizumab. So let's talk about acute sickle cell pain management. This is the acute crisis that they usually present to the ER or doctor's clinic. Oops. Oh my gosh, I'm sorry. All right, so to the kids here, blame your parents. They gave me the pictures. Okay, so acute sickle cell management. The NHLBI and American Society of Hematology actually categorize sickle cell pain as ESI2 triage. So that's Emergency Severity Index 2, which is emergent and is at the same level as someone who comes in with cardiac-related chest pain or asthma attack, where there's a high risk of deterioration. So in these patients, they have to be triaged pretty quickly, and they recommend that analgesic management begin within 30 minutes of triage or within 60 minutes of registration. And I know there's recommendations out there since 2014, and in fact before that, but as most of our patients experience, this never really happens. The opioid dosing must be based on prior effective therapy in consideration of baseline opioid therapy as well. So a patient that comes in who's already been managed on oral pain medication, take account of that, and then we use this morphine dose equivalent, where then we look at what dose of IV pain management would be appropriate. Or if the patient has a pain plan already where they know what the dose is, that's the dose that they should start off, not something based on what they look up in the book based on weight. The patient should be frequently reassessed every 15 to 30 minutes. And then if IV can't be administered right away, then use non-IV routes. Like in Sunrise Pediatric ER, we actually have a protocol where they use intranasal fentanyl. Unfortunately, we haven't been able to use this in the adults, and it has been shown that it's not as effective because the dose that's needed is a little higher. But we can use sub-Q initially until we can get an IV in. So this is just an algorithm that's out in the NIH guideline, where when a patient comes in with pain and it's determined that it's sickle cell pain and not due to something else, then they should be triaged pretty quickly and reevaluated frequently, and pain management or IV pain doses should be adjusted accordingly to relieve the pain as quickly as possible. And then in addition to that, if they do end up being admitted, then a short course of non-steroidals like Toradol or ibuprofen should be added or can be added, especially if there's no other risk such as renal concern. American Society of Hematology, or ASH, actually does not recommend any steroids. This was used in the past, but we have learned that if we start them on steroids to reduce inflammation, it can actually trigger pain later on again. Interestingly, I've seen this in a lot of conferences where if the pain is so severe and not manageable on the doses of opiates that we've used, then if the centers have like an ICU unit or a center that's familiar with this, they recommend sub-anesthetic doses of ketamine infusion. And what this does is actually it makes the opioid effect more effective. And then when feasible, consider regional anesthesia. So that's like subdural infusions of pain meds. Then there's non-pharmacological therapies, and ASH guidelines suggest things like massage therapy, which we're going to hear about more later today, yoga, using TENS, virtual reality, and in some kids we have used this where they have this special thing that they look at to distract them, or guided audiovisual relaxation. And this is used in addition to the standard medications that we use in management. So that was management in acute pain. But as you saw earlier with this iceberg, that acute pain management is only the tip of the iceberg. A lot of our patients live with chronic pain on a day-to-day basis. And chronic pain in sickle cell is defined as pain that is experienced or lasts more than 3 months. Nociceptive pain, so this means pain that is due to, that you feel with a physical damage or something that can potentially damage the body. That is the hallmark of acute sickle cell pain. But chronic pain is often associated with neuropathic pain. And this is the pain that in that initial diagram that I showed, where over time, your body becomes more sensitized to pain. And so it becomes easier to feel pain and more persistent. The pain becomes more persistent. The pain in sickle cell epidemiology study, that was the study that I described with the iceberg picture, reported that adults, 55% of adults with sickle cell disease live with pain. And in that study as well, they actually reviewed some children, and about 9% studied lived in pain, chronic pain. And the types of chronic sickle cell disease pain, the etiology is unclear. It may be extension of recurrent acute painful episodes, or it could be tissue specific, such as avascular necrosis or someone who suffers from leg ulcers. Chronic neuropathic pain has 2 etiologies. It could have occurred from tissue damage secondary to frequent vaso-occlusive crisis that supply the nerves, or because of persistent chronic pain resulting in inflammation that leads to neuropathic pain. And someone had asked this question yesterday when we were talking about new medication, that they asked, why is it they're already on these medication that modifies sickle cell, but they're still suffering from pain? And part of this is because of the chronic damage that's already occurred. So even though you're stopping the acute sickling that's happening right now, unfortunately, the damage from frequent and years of acute pain has resulted in this neuropathic pain, which is perceived as chronic pain. And then breakthrough pain occurs when there's a flare-up or sudden pain, which is unresponsive to their usual pain medication. And in chronic pain management, the aim is really to restore function and improve the quality of life. Chronic pain is often associated with other conditions that enhance its chronicity, such as depression, anxiety, feelings of despair, insomnia. Sleep is really, really important, and a lot of our patients suffer from lack of sleep. Feeling loneliness and helplessness, and then post-traumatic stress disorder. And then, of course, their dependence on pain medication because of how frequently they have to take it. So first of all, we'll try to manage chronic pain with non-opioid medications. Determine the cause first. Is it avascular necrosis, leg ulcers, or others? In sickle cell disease related identifiable causes such as avascular necrosis, where there's damage to the bone from recurrent pain, the American Society of Hematology actually recommend a trial of SNRI, which is actually a form of antidepressant. But it has been found to be effective in this type of chronic pain in patients. Sickle cell disease related unidentifiable cause, where we can't find an actual, such as an actual cause like avascular necrosis or leg ulcers. They also recommend a form of antidepressant in addition to pain medication, or tricyclic antidepressants, and also consider a neuro a neuropathic pain medication such as gabapentin or pregabalin. And this is based on a study that looked at the type of chronic pain these patients experience, which is very similar to fibromyalgia. So pregabalin is Lyrica, which you've heard patients with fibromyalgia are prescribed. Other forms of therapy that are non-medications or non-pharmacological, things like behavioral pain management or cognitive behavioral therapy. So these are through counseling. And then other strategies as well. These are other kind of counseling type or behavioral type modification, acceptance and commitment therapy, mindfulness-based treatments. Some of the big academic centers have actually training sessions that they offer their patients. And then other integrative approach, such as massage therapy and acupuncture. And then when we have to use opioid, American Society of Hematology suggests against using chronic opioid therapies unless the pain is refractory and you've tried other modalities and they've failed. So first of all, optimize sickle cell management. Make sure they're on good doses of hydroxyurea, make sure they're leading a healthy lifestyle, etc. And then do this in collaboration with a pain specialist. We should look at risk stratification, make sure that, there's nothing else that could make them more dependent on the medication, and do a comprehensive assessment of behavioral risk as well. And then start off with the lowest effective opioid dose and avoid any use of concurrent benzodiazepine, alcohol, or any other sedating medication as much as possible. So the NHLBI, the NIH recommend use long and short-acting opioids to manage chronic pain that is not relieved by just short-acting opioids. And then at the same time, encourage patients to increase fluid intake, take lots of fluids, maintain high fiber intake, because as we know, opioid therapy can cause chronic constipation, and use stool softeners to stimulate the bowel. And then also make sure we evaluate for other mental health disorders, such as depression, referral to psychiatrists and other social workers as necessary. So that's the pain medications and pain management. And then, we do see some hematologists recommend chronic transfusion therapy when all else has failed. So ASH suggests against chronic monthly transfusion therapy as a first-line strategy. However, if all measures have failed, a trial of monthly transfusion may be reasonable. But that also has its complications and side effects. And then other things to consider, IV access is usually a problem, because by then our patients have had many IV access in the past for their pain management. So it's hard to find a good vein to do the transfusion. So they might need a port. And then there's iron overload as a complication from chronic transfusion. So we have to make sure that they are compliant with chelation therapy. And some of this can be avoided if we do something called exchange transfusion. And that, we heard this talk yesterday where Dr. Pakwas talked about exchange transfusions. But again, IV access can be a problem for that as well. So just some pictures of our patients receiving transfusions. And I think I'm at the end. So the conclusion here is, first of all, prevention is important. So make sure we optimize sickle cell disease management. So talk to your doctor about hydroxyurea or some of the other newer medications that's out here, that's been FDA approved recently. There is significant variability in the approach to pain management in sickle cell disease. There's no one treatment that fits all. And then provide individualized interdisciplinary pain management. If possible, create a pain plan before having to go to the ER. So you have something that you can show the ER doctors, this is what usually works for me. And most importantly, believe the patient. with that, I'm going to leave you with this picture. I think a lot of you have seen this art by Hertz Nazar, who's a Haitian American man with sickle cell disease. This is his interpretation of, yes, my pain is real. Thank you.
Thank you, Dr. Rashid, for all the wonderful information. A lot of us are still going to wade through that. So I don't know if I could use the word glad, but 55% of adults live with pain, those who have sickle cell. That's something else. But thank you for the information. I'm also being told that pain alternatives might help if used routinely, not sporadically. Our next guest that's going to be talking to us is Shatira Calhoun. She is going to be talking to us about her experience. She's a young adult sickle cell warrior in her 30s, mother of 4. She's bridging the gaps. She's part of Bridging the Gap support group participation. She's had some challenges in the past, but more recently has experienced heightened challenges with sickle cell disease. She's here today to tell us a little bit about them. Now, Pam, who she calls mom, told me that she grew up without knowing anyone who had sickle cell until recently. I understand that she came to know Pam and Bridging the Gap through advocacy efforts that were made when she was in the hospital during a sickle cell crisis. But I'll let her tell you more about her experience. Welcome, Shatira. Please take the floor.
Hi, like she said, my name is Shatira. I met Miss Pam, I want to say last year, at the end of last year, right before my birthday. Could have been the beginning of this year through a friend of mine. I was actually in the middle of a crisis and she instantly reached out, came and saw me in the hospital. It was my first time getting my double port that I needed to get. Dr. Rashid was just talking about the blood exchange, and I'm actually a person that receives that therapy. I get the plasmapheresis or apheresis exchanges once a month. I try to, me and my doctor can schedule it at the right times. The ports though, they are really like, extensive for that treatment. I just got my second one put back in and it's terrible. I went through about maybe 4 ports in the last 2 years. They've been getting infected somehow. I'm not really sure. I do suffer from iron overload. I'm not on hydroxyurea or any other preventative measures like to avoid the crisis. So I'm guessing my doctor is trying the exchange method for me. At the beginning of the year wasn't really working too well. It's kind of getting better. I've been out the hospital for the last 2 months. As far as my pain medication, I only take one. I take oxycodone. I'm not able to get anything else for a breakthrough pain or anything. So I actually started looking for alternative measures. And I actually make CBD, THC, like edible things. And it helps my pain and it actually helps me with appetite. Since I have the iron overload, I do extensive chelation treatments, and I do them 5 days a week for 12 hours a day. And I don't know if that's what affects my appetite, but the edibles that I use, it kind of balances it out. Dr. Rashid really had me going. I kind of actually liked the things that she was saying. I think that a lot of doctors should hear what we say, because a lot of times I go into the emergency room with a pain maybe at a 7, and before I can get comfortable, I'm gonna be at a 9, because I didn't have to go through it with this person or that person, and it's a little, challenging to be a patient and having to go somewhere to try to get help, and you're feeling like you're fighting for your help. uh, I wish more people listened to what we said, because I don't know about everybody else, but I wouldn't be there if I didn't absolutely have to be there. I am a single mother with 4 kids, and that takes up a lot of my time, believe it or not. I don't really enjoy sitting in the hospital. I'd rather be at home with my children. I'm not really sure, you know, what else I could say at this point.
Shatira,
Yes,
you
ma'am.
did good. You did
Thank
good.
you.
That's what we wanted to hear, your experience. And
Okay.
you've told a lot. So I'm just happy that you're able to be here today. So
Thank you
know that
for having me
you're
and
in the right
everybody.
place. But thank you for updating us on your experience. And I'm sure there's some more information to come to help you.
Yeah.
Okay,
Yes, I
thank
want
you.
to keep listening. Thank you.
Yes. Now, everyone, I'd like to introduce to you our next speaker, our next guest speaker, who is a doctor, Dr. Carmen Jones, excuse me, Dr. Carmen Jones. Her topic is going to be on cannabis as medicine. I understand the doctor is a supervising physician with more than 8 years experience in helping patients understand how medicinal cannabis can help them. So we want to hear what Dr. Jones has to say about that. Dr. Jones, you have the floor.
Good afternoon, everyone. Thank you for having me. This is a topic that I know is going to draw a lot of interest, because it's drawn a lot of interest for several years around the entire country, world perhaps. I have a slideshow that I'm going to talk through to give you guys some educational background, and then we'll talk about how it relates to cannabis. Before I do that though, I want to just kind of fill in the blank for everyone. Like, how does a medical doctor go from practicing regular traditional medicine to doing cannabis medicine? And the answer is kind of interesting. I explain this to people whenever they ask. I was trained in pediatrics, so I am approaching actually nearly 30 years as a physician, and I did pediatrics exclusively pretty much since probably about 5 years ago. And what I started doing was seeing cannabis patients, because one of my colleagues asked would I, fill in for her one day. And as it turns out, all these people were coming, for the majority of them, to give it a try. Very similar to what Dr. Rashid said, they have pain, and there's so many different choices, and not everyone is very certain about what to do about it, how to deal with it, how much of these opioids can I continue to take. And what I learned was that my skills at learning how to talk to small children who don't necessarily know how to explain their pain to me was actually translating very well with adults who had similar experiences, not able to truly describe how bad their pain was. And as you guys all heard, sometimes it's difficult for my fellow physicians to judge whether or not that's accurate, real, or even what medicines are necessary sometimes. So I had patients coming back saying, oh my God, thank you for doing this. My life has been changed. And I promise you, everyone, if I heard that once, I heard it at least several times a week, as I have been seeing these medical patients for medicinal cannabis. I use those words intentionally. I want to continue to remove the stigma of that word called marijuana. That word was placed on the plant to, in fact, scare people at some point. And I want to continue to use the medical or scientific biological term, which is cannabis. So that is why this is medicinal cannabis. Cannabis is medicine. So let's go to the slide first, next slide. I'm just going to give you a brief rundown of what I'm going to talk about. I will not linger on some of the basic stuff, just kind of go through it so that we can get to the meat and bones of everything. But let's start with the history of cannabis. It has been around since essentially the beginning of time. You can go to the next slide. You can kind of take a look at what I've written there. But in terms of documentation, we have the first documentation of cannabis being identified in the Far East, well over 10,000 years ago. Hemp was one of the earliest plants to be cultivated. Later, they learned that it could be used in food source, making clothes, ropes, paper. First documentation of it being used as medicine that we could identify was also in China, etc. All the way to America, where we know many people have learned that George Washington and the colonies grew hemp. Thank you. This is a picture. As you guys can see, cannabis is not new to us being used in medicine. This is just the early 1900s. So maybe 80 years ago, where we had cannabis in our medicines. So as you guys can see, one of them says, see very, very clearly, cannabis indica on the bottle on the left. Look on the bottom right, this says infant relief. And they were using cannabis in there. They also had chloroform, so probably not so smart. But that's the point, that cannabis has been used the entire time. Let's go to the modern history. To date, the way we have it now is various jurisdictions around the world began to ban cannabis for one reason or another around the 1800s. And as we fast forward, we kind of all know the rest of the history, that there was a marijuana tax placed based on well, let's say they were leery of the immigrants from Mexico who smoked this, hence the name marijuana, on the docks, and implemented a tax so that they could try to criminalize it. Fast forward, we have the 70s, now we have the hippies, and we have the Vietnam vet protesters. And President Nixon did not appreciate any of that. So he repealed the marijuana tax and then criminalized it by making marijuana a Schedule I drug, along with heroin, LSD, and ecstasy. This means that they believed it had no medicinal value. I should rephrase that. Whether they believed it or not, that's what they did. They told people it had no medicinal value and banned it so that therefore they could criminalize it. Fast forward, because as many of you know, people never stopped using cannabis. However, they were risking their life and their freedom, essentially. California became the first one to rise up and say no more with the Compassionate Use Act of 1996. I want to have everybody kind of take note of that word, compassionate use, because that's something I'm going to come back to later. That's very, very important in terms of what we want to focus on here. Even further, fast forward to 2018, the Farm Bill allows for legalization of hemp, hence the explosion of farmers all over the country started growing hemp. It's part of why you see all the CBD everywhere. And most recently, we had 5 new states come in to some form of legalization, allowing all but 7 states to have some form of cannabis use or decriminalization laws on the books. Yet, our federal government continues to keep cannabis on the Schedule I, no medicinal value spot. And clearly that's a political argument. And I know that one of my colleagues later will be addressing some of those things. Let's move forward. This is what it looks like, guys. These are what we call plant genetics. Let's go to the next one. There's cannabis sativa. This is the most common plant that's used. And this is also where hemp comes from. Some of the effects you can see on the screen, and the same listed for cannabis indica and cannabis ruderalis. The third one, the one that many people have never heard of, is kind of like, because it's a weed that grows wild and not yet available, or have they figured out how to use it commercially, at least to my knowledge. But everyone has heard of sativa and indica. Some people say sativa, think of the sky. And if you think back to the previous slide, it was kind of like a long, skinny, tall plant. The indica, they say cannabis indica, and the way you think about its effects is they use the phrase that says indicouch. So you kind of think about relaxing, short, bushy, lazy kind of feeling. And as you can see, there are some associated medical benefits that I've listed there. Everything you have to remember is associated and or, I don't want to say anecdotal. There are studies that are out there. It's just not a lot. And there are still doctors and people that are concerned that we haven't done enough research on the plant, but I disagree, and I will go into that later. Let's move on, please. People want to know, okay, well, what's the difference between hemp and marijuana? And the difference is these are both strains of the sativa version of the plant, but the hemp plant, and they actually are very difficult to distinguish when you just have the leaf in your hand. If you see the entire plant, you can tell the difference. Or sorry, the entire plant, you can tell the difference, but just looking at the leaves, they're essentially first cousins. So the difference is hemp contains less than 0.3% of THC. Marijuana can contain significantly more, the marijuana version of the plant. But hemp contains a lot of what I call the CBs. So a lot of people know the phrase CBD, but what they don't realize is there's a lot of other CBs involved, including, I'll just run some real fast, CBG, CBN, CBC, CBDA, etc. I will explain what those are later, but the whole point is hemp can be used for not only medicinal purposes, but industrial purposes, as I mentioned earlier. And also it has such a low THC, you don't have to necessarily worry about the euphoric feeling that we often associate with the marijuana version of the plant. Let's go on, please. This is the meat of everything, how cannabis works in the body. So anybody that has done a little bit of research has come across this phrase, the endocannabinoid system. This is important because it's actually a fairly new discovery. This was only identified in the early 1990s while people were doing research on THC. They happened to find an association between the THC receptors that they were finding and the entire system in the body. Everyone has heard of course, the neurological system, the cardiovascular system, the musculoskeletal system. But what we didn't know is we have this, what they call the 12th system, the endocannabinoid system. And this we have come to learn, and believe me, they're still studying it extensively, come to learn that it plays a functional role in sort of, I like to just say homeostasis, making everything right in our body, including our sleep, mood, appetite, memory, and reproduction and infertility. And the important part about this is whether we use cannabis externally or not, we still have this system, and our system can make its own cannabinoids, the chemical that connects with the system. Everybody who has run a long distance runners, I should say, have heard of something called the runner's high. That feeling that comes over them and that allows them to keep going. That's that endocannabinoid system kicking in. It can be upgraded, it can be stimulated by various other things, including some diet and exercise can stimulate your mood to pick up through this same endocannabinoid system. Let's move on, please. This is a graphic. The next one is a graphic about how it kind of can be thought of in the body. This is extremely schematic, not hardly accurate, but you get the picture. We have two types of receptors in our body for this system. And right now we will call them CB1 and CB2. I understand they're working on the third, identifying the third receptor, which they hope later will address the issues of Alzheimer's and Parkinson's. So for now, we know about CB1 and CB2, and these are the areas in the body where it tends to have its effect. Typically, THC, I'll use this is all very loose, guys, not very scientific. I'm trying to make it friendly for people to follow along. The type 1 receptors typically react or respond to the THC products. The type 2 receptors typically react or interact and respond to the CBD products or the CBs. Can we move on, please? So I've used this phrase a couple of times, cannabinoids and terpenes. And I haven't said terpenes, but cannabinoids come in what I have seen referred to as what they call major and minor. And so major cannabinoids are the ones we've been talking about, the THC, the CBD. These are larger chemical components that interact with the endocannabinoid system I just mentioned. The smaller cannabinoids or minor are called terpenes. These are the things that give the plant its fragrance. It's not only found in cannabis. Think about what makes an orange smell like an orange. What makes lavender smell like lavender. It's kind of like the essential oil of the plant. So these things, terpenes, are found, it's a botanical phrase. So these are found on plants all over. But as it turns out, cannabis has over 200 terpenes that are known, and they contribute to the effectiveness of the plant. Just like with the THC and the CBD, those are only two of anywhere between 80 to 100 known major cannabinoids. So if we only talk about the THC, we are missing the entire, program here. If you look at the bottom paragraph I have, what happens is it's difficult to research this because there are so many compounds within the plant. They call it a dirty plant. And they do that because from a research standpoint, it's very difficult to just isolate the one chemical to study it. They have done it, but what happens is they can't even be very accurate on its effects, because what if it takes this major one with this minor one to give this particular effect? So I like to talk in terms of whole plant. I am a believer in the whole plant. I am not an advocate for only narrowing it all the way down to the CBD or the THC in terms of medicine. And that is because in the bottom paragraph, it says researchers call the combination of effects caused by these cannabinoids the entourage effect. And so what that means is they all kind of come together to form a reaction within your endocannabinoid system. And that is very difficult to study. They're very difficult to prove, because not only are the plants so complex, our bodies are complex and how we relate to it. Let's move forward, please. All right, so you might ask, who's out there using this cannabis? Everyone knows that in Las Vegas, or I should say in Nevada, we have both medical and recreational cannabis. I promise you the majority of the patients that I see are senior citizens. And this report by the CDC validates my experience, saying that middle-aged and older adults are more likely to, they're using the word smoke. I would like to use the word consume cannabis. And that is because, think about it, as we get older, we get crunchier. Things hurt. People have arthritis. People have pain. And pain is by far the most commonly used reason for cannabis. Ironically enough, teen usage is down, and we believe that to be just simply because of education. I think also there's always been the misperception that the teens are the ones using and abusing this, and we tend to kind of become obsessive as a society. I'm not saying there's not valid reason to be cautious, absolutely. As a pediatrician, I absolutely understand that, and how we have to be careful with children and teenagers with this medicine. But at the same time, they're just not out there randomly, you know, not to the extent that people might have you think. This statistic surprised me. Average of 7,000 new marijuana users each day. 7,000. Okay, let's move forward. This list here is a representation. It is not complete. It is telling you how the different conditions that we know can help with cannabis. The ones I want to focus on are the ones that we're talking about today. Let's go to the part where, notice appetite loss. When you're in pain, a lot of times you don't want to eat. Your stomach may not be working well. Chronic pain is definitely one of those conditions that are listed here. And you can kind of take a look along the way. One that's not listed that I see a lot of patients for is anxiety. Let's go ahead and move forward, please. This is one of my favorite charts, and I use it when I'm talking to patients. It's difficult to read, but I guess, I don't know if it can be enlarged, but if you look at the bottom right-hand side under whole body relief and protection, it says reduces or eliminates pain. The cannabinoids that are listed there are THC, CBD, CBN, and CBC. This makes my point that you don't necessarily look to just use one of the cannabinoids, but that they can work together. And a lot of people find it interesting because they always go into the dispensary and they look for give me the strongest stuff you have. But that's not necessarily the right thing. And the strongest stuff tends to be the highest THC, which definitely can have adverse effects. So it's not necessary to use necessarily the highest THC product. Go on, I don't want to take too much longer. How does this relate to sickle cell? Well, clearly sickle cell patients have pain, and whether they have it during a crisis or they just walk around and live with it, it is shown. We have some studies here. There's some reference points there at the bottom where cannabis can have a very intense effect on relieving pain, especially the major cannabinoids when they are used together, both THC and CBD. It can also work with the associated symptoms like anxiety, like insomnia. And this is where the compassionate use conversation comes in. You know, it breaks my heart, and I should take that back. It makes me really angry to hear that still in 2020, we have patients being accused of being drug seekers and or not given the proper amount of analgesia when they go to the emergency room. But the whole point here is perhaps if they could use cannabis, it could lessen the intensity and maybe even the frequency of those flare-ups, because cannabis also has a very significant amount of anti-inflammatory properties. And as Dr. Rashid mentioned, a lot of the problems that are triggered are caused from the cellular level, causing an inflammatory response within the body, not without the body. So if cannabis could even help a little bit to tamper some of that down, we may be ahead of the game in being preventative. Please go forward. So in case you wanted to know what it looked like, there's lots of ways to consume it. You do not have to roll up that blunt like you see the rappers and rock stars doing on videos. There are people who do not choose to smoke or inhale. So you can use edibles. They have infused drinks. They have the dropper. We call those tinctures. So The thing that may surprise you is even vaginal and rectal suppositories. And I did have several cancer patients who chose to use it that way because they could not eat. Let's move forward. This is really quick. 76% start using marijuana or cannabis because the medicines they were given were not working. The other 74% say that they did not like the side effects that they were getting from traditional pain meds. And finally, most everyone would recommend cannabis to be used as medicine, those that have tried it successfully. Go ahead, please. All right, so we already have legalization and or decriminalization in the, 85% of the country. So my hope is that very soon they remove it from the schedule so that we can continue to regulate it and make it available for people who need to use it. Please go forward. Everybody, we need to laugh sometime, but I think Smokey said it best. Weed is from the earth. God put this here for you and me. Take advantage. I'm done. That's my time. Thank you very much for having me.
Thank you, Dr. Jones. That was wonderful. The one big takeaway I had from what you said was cannabis is medicine. Cannabis is not marijuana. We need to look at it differently. So thank you for the information that you've provided. I'd like to remind everybody, or at least advise everybody, that you can put questions to Dr. Jones in the chat box, or for any of the panelists. Please put your questions in the box, and we will talk about them a little bit later. Dr. Jones, thank you for all the information. It was wonderful, and we look forward to hearing more about cannabis as a medicine.
Thank you.
Okay. Now we're going to go to our next speaker. Our next speaker is Roz McCarthy. Her topic is Community and Patient Advocates Support Medical Marijuana, Know Your Rights. She's the founder and CEO of Minorities for Medical Marijuana Incorporated, a national nonprofit organization representing the cannabis and hemp industry. She's also the CEO and president of the Genesis Group, a full-service cannabis consulting firm, and managing partner of Plant Life Company, a full-spectrum cannabis nutrient company. She's also a mother to a sickle cell warrior. So I suspect she'll have some illuminating information to share with us about her experience. Go ahead, Roz, you're on.
Thank you, Cheryl. Thank you for having me. Thank you to all my sickle cell family practitioners, patients, caregivers, supporters. Yes, my name is Roz McCarthy. And first and foremost, I am a sickle cell mom. My son, Brian McCarthy, is a 22-year-old awesome young man currently in school at FAMU, pursuing his degree in pharmacy. And he has just been a warrior, and that is what his name, Brian, means. And so it's my honor to be with you guys today, and thank you so much. I'm going to share my screen with you a little bit. First, sharing with you a little bit more about, let's see if we can get, and we may have to, and if, if I have my background, if you guys have that screen for me, just in case if mine doesn't pop up. But let me just share a little bit more about what I do and what I've been doing in this industry. Again, Roz McCarthy, I'm the founder and CEO of Minorities for Medical Marijuana. I started this nonprofit organization in 2016. I'm based in Orlando, Florida. And literally I started this organization because my mom passed away from breast cancer in 2005. And at the time, and my son, of course, is a sickle cell patient. He's and the conversation more about medical marijuana and how it affects patients. And I started just doing my own research. I started looking into it more. I felt like the state of Florida was getting ready to go legal, and there was no community organizations that were talking about, How's this going to relate to the minority communities? How's this relate to our patient healthcare experience? And so I decided, and I named it exactly what my community and folks know of it at the time. At the time, the use of cannabis was still not being utilized. And so I named it Minorities for Medical Marijuana, because we are still struggling to be able to balance and have healthcare equity in our country. And we need to understand more about this plant, what it means, and how do we advocate for it, and how do we know what our rights are? How do we understand more so about how we can normalize this plant? So to the next slide. M for MM, again, is based in Orlando. We have 27 chapters throughout the country, and we do have a chapter in Nevada. So we're super excited to be a part of you guys. Our website, our information is at the bottom of the screen. Please make sure afterwards, please reach out to us and or go to our site and learn more about us. As you heard from Dr. Jones, and shout out to Dr. Jones, I met her, it's been over a year now, and she's just a fantastic woman, a fantastic practitioner. She's someone that's very passionate about this plant. And as she shared with you guys, like, we're not just starting talking about cannabis, like, please understand this plant has been around for years and years and years and years. When we looked at the 1600s in American colonies, George Washington, when she talked about the fact that the cannabis plant has this great cousin called hemp, and it's the same plant, it just has a different variation of the chemical compounds. George Washington in Virginia was growing hemp like it was nobody's business in the 1600s. This plant was prevalent everywhere. During World War II, they had farmers growing hemp. It was making products like paper and plastic and you name it, it was being created. And so as time went on, you have to understand that this particular plant started to infringe on other businesses like plastics and other different commodities like cotton that were coming along, because there's so many purposes that you can have for this plant. Next slide. So again, once we went in, after you went to the 1600s, and after you saw the proliferation and utilization of this plant and what have you, and then you went into the Marijuana Tax Act, which happened in 1937. And basically, it started putting a tax on this plant. It put a tax, and it was the first time that you start to see regulations, and maybe there were regulations that really stepped over the lines of boundary. This is when you saw some of the other industries start pushing out this plant from a medical perspective, as well as from an industrial everyday use perspective. So the state laws later made cannabis illegal. Next slide. And then of course the Controlled Substance Acts of 1970 happened. And basically that's where you have Schedule 1, Schedule 2, Schedule 3, Schedule 4, Schedule 5 drugs. So when this passed in 1970, basically marijuana and hemp. So mind you, you already have folks that are talking about, well, you know what, the effect that you get with marijuana has a psychoactive effect, so therefore it should be scheduled like with LSD and heroin and cocaine. However, hemp, which totally has a non-psychoactive, none of that compound in the plant, that plant as well was made a Schedule 1 drug. So if you understand scheduling starts at Schedule 1, goes down to 5. A Schedule 3 is like a Tylenol with codeine. So just know that they basically said this plant was so detrimental to individuals that we're going to put it to the very, very highest schedule, and we're going to make it almost impossible for the use of, even from a medical perspective. So when you're talking about legalization, and you talk about, or I should say illegalization, and you talk about Black and brown communities going to jail, it's because of this act where it made it illegal, that if you were someone who were utilizing this plant, you didn't realize at the time that it was helping you from a medical perspective, and you were using it because you felt like, man, you know what, I feel better. When you have PTSD, PTSD is just not a wartime psychological effect. You can have urban PTSD. You can have childhood trauma that if you're utilizing cannabis as an option and you say, man, I feel better, I'm less stressed, I have less anxiety, that's because there is a there is a part of the plant that is interacting with your endocannabinoid system and it's making you feel better. Guess what? It's a medicine. When I take ibuprofen, it makes me feel better. So when I'm here today for you guys is to empower you, to give you some of those little nuggets to help you be able to understand that we can normalize the use of cannabis. And it's not saying I'm going to be a pothead, a weed head, I'm going to go out here and smoke till I'm crazy. No, Dr. Jones really outlined there's so many different delivery systems of this plant that you don't have to go smoke. Let me tell you, I have a herniated disc. And with my disc, I have a topical. I put that topical on. When I have a sciatica nerve damage and I have that pain go down my leg, and I put this topical, meaning it's a cream, I rub it on that area where I feel pain, that pain goes away almost instantly. So we have to get ourselves, we have to normalize the plant. We have to start looking at it. We have to do our research. We have to be active participants. Next slide. Dr. Jones, she referenced this again, and this particular number is wrong. So let me give you the right number. As of 2020, there's 33 states who have a medical program. There are 17 states that have a medical and adult use program, which means 17 states are saying it's legal for medical use and for if you want to utilize it just because you have no medical reason, but you just want to utilize the plant, you have permission. It's decriminalizing the plant. It's saying it's okay to, and that includes Nevada. Our work in Nevada as an organization is focused on a couple of different things. One, we believe health is wellness. If you don't have good health, you cannot have wealth. You cannot have having resources and options that you want to see in your life. We want our community, and I will say it and be very specific, I want the Black community to be more healthy. I want us to have more options. I spent, prior to starting M4MM, I was in the palliative care and hospice industry. And I don't want to see us utilizing opioids and utilizing different, different narcotics when we don't have to. I just want us to be more educated. I want us to be more empowered. I want us to feel like we're not going to be targeted. And this is why we created M4MM, to give us that umbrella of covering of support. And in Nevada, if you have any type of medical issue that you think cannabis may be an option for you, I encourage you to go look into it. Don't feel ostracized. Don't feel like it's not meant for you. Don't feel like, man, I can't ask these questions, or they're going to look at me like I'm crazy, or they're going to take me to jail. We want to empower you. We want to get you fired up. That our sickle cell our warriors out here, you do not have to live in pain. I just recently, my son, again, he's 22, and he just recently got his medical marijuana card. And so his first time going into a dispensary, I made a phone call. They said, yep, bring him in. We got him, Roz. And so I brought him into the dispensary, and there was a manager there and there was a bud tender. So when you go into a dispensary, and next slide, we're going to talk about more about this. And then, and again, we did sickle cell anemia. You guys, again, know some of the preventive pharmacotherapies. We'll go next slide, because I really want to get into, the management of your sickle cell pain. How do you manage it? You can manage it from a non-pharmacologic standpoint, or you can manage it from a pharmacologic standpoint, meaning by non-opioids, adjuvants, alternative medications, and opioids. What alternative medications are, or you can look at this as a holistic medication or option for you. That's what cannabis, in my opinion, is. Next slide. So it's been discovered that medical cannabis can enhance the patient's mood, but more research is needed for long-term pain management. So again, we're seeing, one of the issues with the fact that cannabis is a Schedule I drug, the research that's needed, the actual research that's specific to our community has not been done. So a lot of the information and insight that we're getting about this plant and how it has a positive effect on sickle cell patients is anecdotal. That means someone takes it and they tell the next person. The next person says, man, I did this and this worked for me. There's an app, and I want you guys to write this down. All my sickle cell patients, there's an app, and it's a young Black brother, he created this app. It's called Tetragram, Tetragram app.com, tetragramapp.com, or go to Tetragram app on Instagram. Basically, it's an online, on your phone, where you can take and you can look at exactly what you're like taking, when you take it, how it makes you feel, what works for you. Not only that, you're able to interact with other people who are journaling what they're taking and how it made them feel and what relief they got from it, which is, it's so exciting because now we have patients talking to patients. If you are a physician, you can access that app and you can go and look and see what is working for patients. Because right now we don't, from a dosing standpoint, and I know I'm not a doctor, I'm not a physician, I'm a mom who has a kid who I was like, Abby, darn it, if you're gonna be arresting my kid and making him feel uncomfortable, he's gonna be able to look at this plant and use it and see if that can help give him benefit. And so you're looking at this, sometimes when it comes to dosing, there's no specific, like when you take a Tylenol, you take an ibuprofen, there's recommendations, or when you're prescribed medicine, they prescribe, they're telling you, take this then, take it in the morning, take it with food. With cannabis as a medicine, we're still trying to figure that out. We're still trying to figure out what's the dosing. And so one thing I always tell people is start slow, start low, go slow. Meaning, if you get a gummy, if you get an edible, if you're out for the first time, go gangbuster, try a little, give it some time, see how it works, see how it interacts with your body. If you start feeling relief, great. Go in your journal, go into tetragram, put down when you felt that relief. If you're not feeling relief, go maybe take a little bit more. See if you get more relief, see if you get some relief. And that's right now, due to the fact that cannabis is so new from a pain management perspective, these are the type of ways that we're being able to look and figure out what works and what doesn't work. And I know the follow-up to this conversation, having Dr. Jones and other Dr. Rashid and physicians who are very comfortable about cannabis talking about dosing and how it's still a work of art. We are still figuring out what's the right fit for certain patients because it really, it differs. And then of course, you know, we have the studies that are saying that cannabis can be an alternative for opioids. Next slide. So know your rights. And this is the part that is just critical. Do you guys know that if you are a patient and you want to look at options for yourself, that you can, you qualify. The state of Nevada doesn't have sickle cell, like some diseases they have, like epilepsy, fibromyalgia, cancer. It's very specific. If I have cancer, very specifically says I would qualify for a card. However, it doesn't say sickle cell anemia, you qualify for a card. But what you do have is you have a chronic pain that's related to the primary disease state, which is sickle cell anemia, which any physician who's a recommending physician. So remember, they're not going to prescribe you cannabis. They're going to make a recommendation based upon your past history and your current issue and your medical condition. You may benefit. May is the optimal word. You may benefit from the use of cannabis. So I'm going to make a recommendation. Just go back one. So I'm going to make a recommendation for you to be able to purchase your cannabis. So when you go to that doctor, ask questions. When you go and you get your medical card for the first time, take your, your last, patients. When you've gone, if you got the transfusion or if you got anything that shows that you have sickle cell anemia, anything that shows that you've been treated with pain medication to support you and having a pain-free, to be in a pain-free disease state, take that, it could be one sheet, it could be 2 sheets, it could be your whole entire file folder of your records. But if you take 1 or 2 pieces of documentation showing one, your name, your address, your date of birth, and that you have been diagnosed with this disease, and you talk to that physician, and you talk to them from a perspective of strength, talk to them from a perspective of, I want to understand my options. Don't have, if they try to rush you through the process, stop them. Don't allow anyone to rush you through the process. But again, Nevada has a state-run registry where you can participate in. You can get cannabis on the adult side, but if you have a medical condition, it behooves you to connect with a physician to ask those questions. Next slide. So again, must be diagnosed with a chronic or debilitating condition and reside in Nevada. This is how you get your card. Patients must register with the state. Registered patients may legally possess up to 2.5 ounces in a single 14-day period. Patients without a dispensary in their county may cultivate up to 12 plants. So again, these are some of the specifics that you really need to think about in Nevada. And if you're a patient, you have to be 21 years old. These are things that you want. And guess what? I got a couple of Black dispensaries that are in Nevada. So let's, on top of that, let's go do business with other Black-owned businesses. That's one of my issues with Nevada, that I feel like there's opportunities for us to be able to get our medicine. You see that Dr. Jones is a recommending physician. So if you want to be someone that culturally connects with you, you have those options. You want to go to a dispensary that's owned by someone from your community, you have that option. You don't have to live in, when I was growing up, it was like, man, if you smoke or if you, it was like you were druggy. You're not a druggie. This is an option for you. This is something that you should look at in a serious manner and be able to ask your questions. This is why we created M for MM. It's all about giving you guys choices. My sickle cell warriors, you deserve choices. I understand it. I see my son, I worry about him. You guys don't understand as a mother. Lord knows I worry about him every single day. If I don't hear from him, I go nuts. But he's empowered. And when he sat down with that bud tender, and that's the person that's inside the dispensary, that person took time with him and walked him through what his options are. If you go to a dispensary and they don't take time with you, and if you feel rushed, get up and walk out, because guess what? You're a consumer and they want your business. You want someone that's gonna talk to you, remind you about indica versus sativa, ask about terpenes, tell them about you need something for musculoskeletal pain, tell them that you need something for when you have that really that intense crisis where you have isolated pain in your joints, when it's in your back, when you need something for that immediate release of pain, to take care of that pain. Next slide. So you're getting registered. Once you confirm, and again, I'm telling you, sickle cell is not on there, but because of the pain that's connected with sickle cell, any recommending physician, once you share and be able to share your diagnosis and show you a proof of that, should 100% support and recommend you utilizing cannabis. If they don't, call us and let us know, and we'll find you another physician. And if you got to pay again, I'm telling you right now, I will pay for it for you. So you got my name, you got my number, you call me. You want to register on the Nevada Medical Marijuana Card Holder Registry, and they'll walk you through what you need to do. If you want to obtain your card, here's the phone number for Nevada where you can find out they'll have referrals for you. When your doctor completes your paperwork, finish your card holder registration, submit your paperwork. There's a $100 card fee, and then you should get your card in the mail. Next question. Next slide, brother. Next question. So once you get your card, that's when you want to find your dispensary. If you want a referral to a dispensary in Nevada, if you want support, if you need someone just to ask questions, please join the M for MM family. We are so committed to making sure that our community has all the resources needed. I may not have all the answers to your questions. I may not know it all, but let me tell you something. If I call someone and I tell them this is Roz McCarthy from M for MM, you better make sure they're gonna hop to it, because I don't play around with them, and especially when it comes to my community. So I encourage you guys, if you wanna be a member of M for MM, please go to our website, learn more about us. We talk about the business side, and I will be remiss, two things. My goals are trying to make sure that we expunge people's records. Black and brown people get you out of jail or clear your record from past indiscretions. And number two, we look at economics and economic opportunities, that we own businesses and we have opportunities to grow with this industry as it starts to grow. Thank you guys so much for your time. I really appreciate it. Feel free to reach out to me at any time. Thank you.
Hear me? Can you hear me, Roz?
Yes.
Okay. Thank you very much. That was excellent information that you provided. Again, if anyone has any questions, please let her know. I really appreciate you talking about the Tetragram app. I think a lot of people get a lot of things from that. I think Dr. Jones even was agreeing to that as well. There was a lot of information you gave, and I just want to say to everyone, remember today's topic is really on holistic therapies for pain. So cannabis is an option, but definitely, like anything that you're going to start new, you want to make sure you're talking to your doctor about it as well. So you have good information to start with. So do that. Thank you again, Ross. We appreciate having you.
Thank you for having me.
Now, our next speaker is going to be Tamika Meadows. She's a young adult sickle cell warrior in her 30s that is one of Bridging the Gap support group participants. She has the SS disease. She'll speak on her experience with using holistic therapies to help ease the pain. I want her, well, I'll tell her in just a moment, but she has a master's degree in social work and is currently working on her PhD. Yay, yay, that's a feat. And she's also an active member of the Zeta sorority. Tamika, I'd like for you, and we'd like for you to also talk specifically about massage, because I understand that you use massage as one of your therapies. Okay, so go ahead, you're on. Go ahead, Tamika.
Hello. You hear me? Okay. Hello, everybody. I'm Tamika. So, yes. So as far as talking about my pain journey, growing up, I didn't have too many crises. Same thing like Dr. She talked. It was 2-3 times a year that I would end up in the hospital. But in the last 3 years, my crises have substantially increased. And so, I did struggle with, in the beginning, using medication. And so I didn't want to be on medication. I didn't want to have to take pain medication. And so I was looking for other ways to be able to help my pain. And so I did do massage through Massage Envy. I had the monthly membership. Since COVID has started, I do not use that currently. However, that is something that I've utilized. Right now, I'm actually looking into buying an office chair that has a massager in it, just because I do like the benefits of a massage. In a lot of these approaches, I always say they don't take away all your pain, but I think they just help with the intensity, and they help with maybe instead of having a crisis every 4 weeks, maybe you can span it out to every 8 to 12 weeks. And so I do like using different approaches. I have my essential oils that I keep at my desk. I keep my humidifier going with my essential oils. I have different books that talk about the essential oils and which ones to mix. And I even use them in the bath sometimes. And so massages, I think, are great. I think they do help with the intensity of the pain. So I have utilized that. I currently, which I actually did today, I do the exchange transfusions. And so I've tried different things in conjunction with the exchange transfusion. I haven't been as great of it recent, but I do also encourage exercise. And the reason I say that is I know for me personally, and everybody's different, for me, exercise, if I do the exercise and I'm doing it regularly, I do seem to feel better in the crisis. Even if I do still have them kind of for good, they don't last as long. Instead of being in the hospital 5-7 days, maybe I'm out 2-3 days. And so I encourage exercise too. I also noticed if I put on weight, I noticed my breathing changes. I noticed that my mobility changes, my flexibility changes. And so I think the exercise really does help with those things. I think hot baths and hot showers are great. I even put sometimes the essential oils in the shower. I'll put some drops down on the floor and it helps. And so I think that those different approaches are great. I very much enjoyed the speakers today, especially I will be reaching out to you, Roz. Something that I've recently been trying to dabble in is the CBD, and the struggle I had was that the THC with the CBD. I also have the stigma. I struggled with the stigma of taking THC and what does that mean and what does that make you and things like that. And so finally I've kind of gotten to the point where I'm like, you know what? I have sickle cell. I have pain, and at this point, you know, it's all about pain management and what can I do to manage it. And if I can use CBD and THC and things like that to do it, then I have been more open and willing to try. And so I do encourage sickle cell patients to not necessarily knock down a lot of, I know we kind of knock down a lot of the holistic approaches because we're like, oh, that doesn't work, that's silly. No, but I think that I encourage everybody to try those approaches because I think they have benefits. Even so, in Dr. Rashid's presentation, she talked about it's not necessarily all about the sickling in the body. Some of it, like what brings that on, and can we stop that to reduce the crisis? So one thing that I struggle with is stress and anxiety, and I've struggled with depression, and I've struggled with those things, and they also lead to crisis, and they make the crisis longer and the crisis are more intense. And so maybe not all the holistic approaches take away all the pain, but if they can take away those things that create the pain, then I think that's good. So I do the essential oils not only just to feel better, but also to help with anxiety, to help with stress relief. And I also use meditation. My favorite app that I tell a lot of people about is Calm. That app has different settings to work with what you need. They have meditation for stress, they have meditation for anxiety, they have meditation for depression, or if you just need like some encouragement, they have meditation for that. And I think that those things are great to clear the mind and relieve the stress and hopefully stop the crisis or not have the crisis. And so I encourage meditation, I encourage yoga. I've tried Pilates before, and I did that with the reformer machines, and I love that. So right now, like I said, going back, I am attempting the CBD stuff. So far, I have not found one that works for me, but I'm not going to give up. I'm going to keep trying until I can find something that works. And so, like I said, I will be reaching out to you, Roz, because I would love to be able to sit down with somebody. Something recent I have started that I'm waiting to come to try is the Mary's medicinals. And I chose to go ahead and try the THC, and I definitely appreciate your presentation because you talked about the different things that I was seeing as far as CBD, the cannabis, the hemp, just the different terminology, and trying to figure out what those different things mean. And so those are some things that I'm trying now, is the CBD mixed with the THC or mixed with the hemp, and I will definitely give updates whenever I can. But those are the things that work for me: massages, exercise, essential oils, and right now I'm going to attempt the CBD with the THC. So yes, that's my pain management regimen and journey and what I've been trying and doing. And so I encourage any sickle cell patient to try other things besides just the opioids and the pain medication, which those are good too, but I just suggest trying the other holistic approaches and try to reduce that stress and that anxiety and just live a better, healthier life.
Tamika?
Yes.
Thank you so much. That was really great. I appreciate it. It sounds like you have an extensive background on trying many different things. I like the one fact that I picked up on was essential oils. I would have never even thought about that, but that's an excellent one because I love essential oils too. So thank you for your talk. I really appreciate what you're doing. If anybody has questions, please submit them. Tamika, thank you for your experience and for being a part of Bridging the Gap. We do appreciate it.
Thank you, and thank you guys for having me.
We have a video that we were going to show from the Caring Place, which is part of the Nevada Childhood Cancer Foundation. We're going to, since we're running a little bit on time, we can show that. We can attach that information later on with the presentations that we are recording. So you won't miss it, but it's a very good presentation from Andrea Rapanos, and it's in regards to the Caring Place and what they can do in terms of providing counseling services. She's a social worker that's in the medical field. She has over 20 years experience, and she had this unique experience in social support, case management, and advocacy for those who were afflicted by chronic or life-threatening illnesses. She's a member of the Association of Pediatric Oncology Social Workers and the National Association of Social Work. So look for that in your package of information that will be recorded. And we also had another speaker. Her name is Courtney Upshaw. She is a massage therapist. She's licensed, and she's also a trainer. She was unable to be here today because she was at a site where she was helping, where they were having a game, and someone got hurt. So unfortunately, she was not able to come on and be with us today, but we'll also provide information on that as well. The next thing that we're going to do is take questions. We're going to have our question and answer session. Before we do that, I'd like to remind everyone again about the exhibitor booths that we have out there. So if you hadn't had time to experience that, please try to go out there and look at the information from all the exhibitors. I'd also like to thank our sponsors once again, and the community-based organizations that put this event on. I'd like to thank them for being able to collaborate and do such a wonderful event to provide us with all this enormous amount of information, but help to make it worth something, so we know how we can overcome the pain with sickle cell. So I'm going to start with some questions and answer some questions, and I'm going to. Sure.
I'm sorry, Cheryl, sorry to interrupt you. Did you want me to start that video?
Oh, absolutely. I thought we were going to do it tonight, but yes, if we have it, then I would absolutely love for us to have the video with Andrea.
Okay, hold on.
Rapanos.
I'm
Okay,
gonna
so
start
here
that video
she is,
now.
everyone. We're going to show you that part. Thank you.
You're welcome.
Almost 30 years now. And we offer a host of services to children diagnosed with sickle cell disease and their families. They usually come to me first. I usually get the referrals from their physicians. We have a wonderful team of social workers who conduct very comprehensive assessments for each family. And the purpose of that is to be able to identify what their needs are. Once we have identified those needs, then we get to work. We get to work and we do what we can to help our families live as healthfully as they possibly can be, as we understand the social fallout of chronic and critical illness. So this is a part of what we do here at the Nevada Childhood Cancer Foundation. Our services are twofold. We have a pediatric side of service here. We also have a healing arts and adult side of service here. Today we are actually on what is considered the healing arts side of the Nevada Childhood Cancer Foundation. It's also called the Caring Place. The Caring Place offers a myriad of services to all of our clients and their caregivers who are registered with our foundation. So we offer things like yoga, meditation. Singing bowls is amazing. Singing bowls is another class that is offered here. Again, it's a form of meditation. Everybody meditates differently. There are some people that need a very quiet space. They need a low light. They need complete silence, no background noise or anything of the sort. You have people who need sound, very specific type of sound, to be able to kind of relax their bodies. And then you have people who do what I call they meditate in motion. So whether, through fluid body movement, through things like yoga, things like dance, even Zumba, which is another service that is offered here. We have a Zumba instructor that comes in to teach that. Just the movement of the body is very healing. It's very helpful, especially for those who deal with things like chronic pain. One of the, I think, biggest mistakes that people make when they're in chronic pain is that they stop moving altogether. And it makes it really, really difficult for them to be able to get rid of that pain. So even when you're in pain, it's always better if you can just keep some kind of movement. So, being able to meditate in motion, through dance and through Zumba, through yoga, things like that is also very healing for your body. We do a lot of massage therapy, a lot of reflexology. So reflexology is great. Obviously, it's with pressure points in your feet. A very skilled practitioner will sit with you, give a brief interview about maybe some of the things that are going on with your body, what may be causing those things. They will sit with you for about a half hour, and they know specifically the pressure points in your feet to be able to pressure on and manipulate, to be able to help your body either feel better or process whatever toxins are in your body, and be able to provide the patient some kind of relief with whatever the ailment is that they are dealing with. So whether it's just, simply a matter of stress management, sometimes even with reflexology can help your digestive system. And it can also relieve pressure that you find in your body. We also do counseling services and group support services here as well. Now you may be thinking, what does that mean for you? Well, I will tell you. Obviously, sickle cell patients struggle with pain. We know that when they're in a sickle cell crisis, it can be 100% debilitating in a minute. So we work really hard to be able to offer an accompaniment as well as an alternative in the way of pain management. And we do that through our healing arts programs. So when folks come to us, they come to us and look for things like reflexology or massage therapy. Obviously, if you know anything about massage therapy, the manipulation of muscles and tissues can really help to relieve their pain. And it helps put them in a better position to be able to manage it and control it, in addition to whatever some of the positions. So we are very proud of our services here. Again, for our pediatric side, it is also open to their caregivers. We understand that chronic and critical illness doesn't only impact the diagnosed child, that it impacts the family. So we work really hard to ensure that our services are all inclusive. So welcome to the campus.
I'd like to thank Nevada Childhood Cancer Foundation, NVCCF, for providing us with that information. I think that the Caring Place is a wonderful place, and it's an alternative to go to get what's needed when you're in pain. So we appreciate her providing that information. Again, all this information will be provided. I think at the end, you'll be able to review the recording of the information. So we appreciate all of our speakers. We appreciate all of our panelists for participating and giving us such great information about pain and pain management. We're going to start our question and answer session now. So I'd like to have all of the panelists aboard. I am going to field the questions, and I may ask for volunteers, and I may just pick someone. So the first question, there's quite a few, so let me start with, the first question is, can you suggest some holistic remedies and suggest how I can get these paid for? I think that's something that anyone can jump in and answer who who has some experience with that. So please, let's have at least one volunteer for that question. Okay, if not, Pamela, do you want to answer that? Oh, okay, go ahead, doctor. Doctor, go ahead and unmute yourself.
Okay, hello.
Now we can hear you.
Yeah, that's a very complex problem because cannabis remains federally illegal. A lot of the services are not covered by insurance. Regarding holistic practices, those are sometimes covered depending on if you have insurance with your job that reimburses wellness, but sometimes people have a health savings account that can be used towards wellness type treatments. Otherwise, it is cash pay for most of these services. And I work with a wellness coach that does all of those things that the caring place mentioned as well for patients, including essential oils. It may have been new to some of you, but it's a very well-used treatment in addition to meditation, breath work, energy work. A lot of people are doing that out there, but unfortunately it is not often covered by any insurance and it's mostly cash pay.
Doctor. The next question is, how does stress and anxiety increase pain? This can, Dr. Nick Rashid, would you like to answer that one?
Sure, yeah. I think I touched this in my presentation. It's actually through the autonomic nervous system, where, you know, just even someone who doesn't have sickle cell, when we have stress, you start to have more anxiety and you have all these symptoms that come on. Like when I am stressed, like giving a presentation, for example, I feel nauseous. I sometimes get a headache or, you know, all these symptoms start to come up. In someone who has sickle cell, it can definitely trigger, and through the autonomic nervous system, it can actually narrow some of your blood vessels or cause constriction, and that can in itself trigger a sickling crisis. But stress can also increase anxiety, and anxiety itself can make the pain worse than what it would normally be. So that's one way.
Okay, thank you, doctor. Okay, the third question I have is, can you describe what is meant by chronic versus persistent pain? Either of the doctors, either of you, if you'd like to give us some update on that one. Dr. Jones?
No, I'll jump in.
Okay.
I think it's similar. Chronic pain is one where it's always there, like a backdrop of pain that you live with. Persistent can mean chronic, or it can mean something that's acute, that's lasting longer than usual. So if your acute pain is usually a day or two, and this one is a little bit more persistent, then sometimes that kind of terminology is intimate. I don't know if Dr. Jones has something different to add.
Yeah, I just want to add, actually, you mentioned it in your talk, Dr. Rashid, that in order to be called chronic, it's usually 3 months, ongoing for at least 3 months.
Right, yes.
As opposed to something that may be persistent that has only been going on for 2 weeks.
I saw a question in here where someone asked, can a child 5 years old use cannabis? I think it was specifically to cannabis.
Yeah. So in the medical program that the state of Nevada offers, they would have to meet with someone like me, and I would have to actually verify whatever condition it is that they want to use cannabis for. I get these patients, the children mostly come in with autism and or seizure disorders. And then what we do is make sure we gather all the pertinent medical records. And then because of their age, I spend a lot of time teaching them what to do. and what not to do, especially. And then I consult as much as possible, or as much as available, as much as the parent wants me to, with their primary doctor, or let's say their neurologist, for instance, in those seizure cases. And then that information gets sent to the state medical director for them to approve, which I find ridiculous since he knows nothing about cannabis. But anyway, that's the law as it stands right now. But I probably see more medical marijuana patients in the state than anybody else. So let me know.
Okay. I think I have another question for you too, Dr. Jones. Can I mix marijuana, CBD, THC, and my pain medications?
So that is often done, but that has to be done carefully. So for instance, I have lots of patients that are veterans. I can't tell you some of the stories that I hear, like, oh yeah, I was blown up in Vietnam, and they have, 2,000 pieces of metal in their body, and they are on opiates chronically, but they use cannabis as well. The problem with that is cannabis is metabolized through the liver. And so what it can do is any of the medicines that you are on, particularly if you only want to try CBD, think it's benign, that cannabis can what we call potentiate the effect of whatever medicines you're already on. And so this is why Roz's advice of low and slow is the same advice we all give. But what happens is people tend to try to use their cannabis while decreasing their opiates, kind of like a titration, titrating up on the cannabis, titrating down on the opiates. The good news is cannabis acts differently in the brain, so it does not have the same deleterious effects with regards to overdose that an opioid might. The opioids work in the brainstem, and the cannabis works in various other portions of the brain, so you do not have that respiratory depression. So yes, it can be done, should be done slowly, carefully, and preferably with the assistance of either your primary physician, your pain physician, or come talk to me.
Okay. Another question that's being asked, Dr. Rashid, you might be able to answer this. I'm sure you're able to answer this one. What is the difference between addiction, tolerance, and dependency?
Okay, so tolerance is when you're needing higher doses of pain medication in order to treat the pain. And we commonly see that in our patients only because they've been exposed to pain medication for several years. So every time they come in, the next time they might need slightly higher dose of medications because they've become tolerant to that particular medication. Sometimes you might change the medications around a little bit to treat the pain. Dependency is when your body physiologically becomes dependent on that opioid. Opioid has a way of changing, we talk about tolerance where you're needing more medication, and then sometimes your body becomes dependent, whereby if you stop the medication suddenly, then you can experience the pain abruptly again. So, in order to stop it, we recommend, a slow wean down rather than just stopping something. I have patients that are on chronic pain medication and they go in for acute pain crisis, and then they come out feeling better, and then suddenly they're like, I feel good, I don't want to take anything. And then 2-3 days later, they have this crashing pain, which is because their body has become dependent on that pain medication. Addiction is slightly different. Addiction is when you're looking for that, I guess, I don't know how to describe that recreational feeling, that high that comes with the medication. So you're actually not really using it for pain, but you like how it makes you feel, and that's what you're seeking. So it's more recreational than dependency.
Okay.
Does that answer?
I think so. Did you have anything to add to that? Was there anything you want to add to that, Dr. Jones?
No, I agree 100%.
Okay. Okay, so then we have a question that either Dr. Jones or Roz or both of you might have an interest in. Is vaping marijuana better than smoking, and is it more useful?
Go ahead, Roz, I'll follow you.
You know what? I think a lot of these are questions that you have a conversation with your recommending physician. It's called a delivery system. And that means there's different ways that you can have the medicine delivered to your body. Those individuals that are concerned about smoking, and especially if you have any type of lung damage or lung issues, and like with my son, he was born prematurely. He was only born 1 pound, 13 ounces. So he had lung issues just as a preemie. And then of course, now having sickle cell, he's had chest crisis and syndromes, several times in his life. So maybe smoking may not be the best preference from a delivery perspective for him. However, for someone else, it may work because the inhalation of utilizing smoking sometimes works better than vaping, and it really just depends. And so I will tell you this, when you first start utilizing cannabis, it's easy to start racking up your cost of looking at different options for yourself, but talk to your physician. If you're not someone that currently smokes and you've never smoked before, it's fine, you can vape. But if you're someone that's not even familiar with that, there's tinctures, there's pills, there's, the suppositories, there's so many different delivery systems, even edibles, we all eat. So if nothing else, there are edibles that give you this, it just takes a little longer in order for you to get that relief. But I'll let Dr. Jones go a little further because I'm talking from a mom and from an advocate perspective, and she'll talk to you from a clinical perspective.
So thank you. So in my slide presentation, I put up several different delivery systems, as Roz mentioned, and every day these folks in the industry are coming up with different type of ways you can use cannabis, but specifically to the smoking of it or inhalation, that is typically used for people who have an acute pain situation. So in other words, it's probably the vehicle that works fastest for pain right now. That person with the nagging back might do fine with a capsule or an edible or something that may take longer, but you're having a crashing migraine, or again, with regards to sickle cell, a pain crises, inhalation is going to be your fastest delivery system. But again, when you set something on fire, like a plant, you unleash several additional chemicals that go into your body. Some people prefer that, don't mind it. I call vaping a clean smoke because you're simply warming up the oil. And I realize that there's controversy, or have been, or was generated controversy around vaping, but to my experience, it is safer, and it's also very discreet. There's something called microdosing. I'll be brief. And what that typically means is that you, for instance, are going to be in a situation where you are uncertain as to whether or not you can get to your favorite flower that you like to smoke at night. But you have pain throughout the day, or anxiety. You have a situation where you may be in an anxiety situation. A vape pen is small, discreet, odorless, and you can go into the bathroom and take 1 or 2 hits, for instance, of that vape pen, of whatever you choose to have in it, based on what I taught you earlier. And you're not, again, getting high. 1 or 2 hits can calm that situation down and allow you to move throughout the day. 2 hours later, check in with yourself. How am I feeling? Am I having pain? Am I having anxiety? Or whatever the condition is. 1 or 2 hits. This keeps your receptors filled. Remember, I talked about type 1 and type 2 receptors. And of course, I always prefer your intake to be balanced so that both ends of your receptors are being filled. This, again, keeps you from being high, but it allows that endocannabinoid system to work in that entourage fashion that I mentioned earlier.
Dr. Jones and Roz, I have to tell you, there's a lot of interest in this subject matter. A lot of our questions are surrounding that. I have a couple more. Someone asked if you, Dr. Jones, if you could be allergic to cannabis, and I just wanted you, although you did answer in the chat, I wanted you to go ahead and verbalize.
Okay, so the answer is yes. It's not common. I have one patient who is allergic to several different terpenes. If you guys remember, I told you the terpenes are the essential oils of the plant. It's a botanical chemical, not a cannabis specific chemical. So again, I'll use the example of the orange. If you are allergic to oranges or orange juice, you will likely be allergic to that particular terpene. So you may not know about it until you have a reaction, but like any other allergic reaction, it would be treated the same with an antihistamine, to bring it down. I have not heard of anaphylactic or life-changing, life-threatening reaction. But again, if you are allergic to a certain terpene, that is the most likely place you would be allergic to, as opposed to THC or CBD in specific.
Okay, and then there was another question along that very same line, Dr. Jones. An audience member said, I have a bad reaction with cannabis, CBD. Does this have the effects from traditional marijuana?
Well, again, I saw that question and I answered that I could help that person, Miss Sheila. But what I would need to ask a whole lot more questions, because I don't know what she means by bad reaction. I mean, someone who is a novice at using cannabis and gets a hold of the wrong or a uncomfortable strain can call that a bad reaction. In fact, the literature talks about it in terms of calling it psychosis. The layperson might call that you get paranoid. The things that you think about if you're my age, when you were a kid and you got a hold of some weed and you got paranoid, that has been expanded to include the word psychoses, because there are some predisposed situations that could cause that to happen, or you didn't use the right cannabis. And please allow me one more indulgence here. I know Braz talked about when you go into the dispensary talking to the bud tender. It's a fun word to say, all that's great. Unfortunately, I do not have a lot of faith in what they know. I need you guys to all be super nerdy. If you decide to go into the dispensary, I want you to know what you're going for. I want you to know what you're looking for. I want you to have done some research. And if you do that, you will be able to have a conversation with that person behind the counter. And unfortunately, my colleagues are light years behind. It is really painful to me that people say, ask your physician. The physician goes, I have no idea what you're talking about. I don't know anything about that. Some of them don't even want you to say the word in the room. Like, why can't we talk about this? This saying the word cannabis or marijuana is not going to get you in jail. However, that is still a very big thought. So that is why I exist. That is why I went ahead and jumped through the looking glass. And I try to help people as much as I can. But I want you to be super nerdy yourself, do the research, figure out what it is you need. If you most people on this webinar will have a medical condition. I want people with a medical condition to get a medical card. There's a difference. Ms. Roz mentioned that. You are showing not only the retail store that this is important, you're making sure that people understand you have a medical condition. I am not in Las Vegas partying on the weekend. I am not just going to get it to get high. This is my medicine. And that with that comes several other benefits. And she mentioned some of them. Some of them were, cost. I call it an insurance card. People have to go to work. What happens if something occurs at work and they do a test on you? It's like, no. I am using this as medicine. Those are just, a couple of the benefits of the card. So, and of course that cost is, she mentioned, mostly on the state.
Okay. Well, thank you, Dr. Jones. I appreciate providing that information, because again, there have been a lot of questions. The last question I'll ask and answer myself. There was an audience member who wanted to know if they could get a copy of the information that was provided today. We will be posting some of the webinars on the website, and they should be available by Monday. The website is www.scunitebtg.com. We have some exhibitors that are waiting for us in the booth, so we want to wrap up. I just want to thank all of our speakers and our panelists for such a wonderful day. Thank you for being able to provide all of the interested parties and their families and their support groups the information you provided today. It's a wealth of information, a lot for us to get through, but it was good. And if we have it in hand, we'll use it. And we will be talking again soon. We have a raffle that we want to wrap up with, and the raffle is essentially we're going to be selecting some winners based on who visited the most exhibitor booths. So please leave a comment if you're there. Also, after we wrap up, I just want to remind or let the audience know that we're going to be emailing a survey. We want to know how we did. We want to know if you enjoyed, if there are some things that we can do better next time. We'd love to hear what you have to say. So right now, I'm going to be passing you along to Lynetta, and she's going to wrap up with the panelists and the collaborators. Thank you all for a wonderful day. Appreciate you.
Thank you so much, Cheryl. You did an amazing, amazing hosting job. I don't know if it's a job. I don't know if, because do we have to pay you to make it a job? I'm not sure, but we thank you. You were excellent. And as my name is Lynetta Barnes, I am the president and founder of Sickle Not Broken Foundation of Nevada. And I'm considered one of the CBOs here in Las Vegas. And, you know, as we close this out, we just really wanted to say thank you to all the community-based organizations. We have, of course, our host tonight was Bridging the Gap, Adult Sickle Cell Foundation of Nevada, DreamSickle Kids Foundation, Sickle Cell Center Nevada with Dr. Nick Rashid. And, you know, as we do this thing called Sickle Cell Unite, Bridging the Gap, we do like to bring all of our Nevada community-based organizations together as one and spread this same mission of awareness and education. So with that being said, I'm going to announce the names of the raffle winners. And then I'm going to pass the mic to any of our other community-based organizations if they want to say any last words of goodbyes. So per the leaderboard, and it was based off who interacted the most, posting and asking questions. We had 3 winners. We had Ferran Dozier, who was a speaker on the 18th for sickle cell trait, Miss Rona Wiggins, and Tina Allen Major. So these 3 amazing attendees will be receiving a small token of thank you for our raffle. It will go to the email that you registered with. And again, we thank these 3 participants for being so active. And we absolutely thank every single one of you here today for allowing us to continue to bridge the gap in education in our sickle cell community. Without further ado, does any of the other community-based organizations have anything they would like to say before we close out completely?
Hi, this is Pam White. I just felt that it was truly needed for me to say something on today. This is one that that I was asked to take on to find someone that can tell us more about cannabis. And so I thank the speakers that came on today. I mean, this was just a very good presentation. I enjoyed everyone. I learned so much about it. I was jokingly saying, when we talk so much about the cannabis, I said, now, Dr. Rashid is having me look like a weed head over here. But it was Dr. Rashid that really commented and wanted to know more about it. So Dr. Rashid, we thank you. We thank you for being a part of our community and helping us to learn more about things that we can do to help with the pain and dealing with this pain. I just can't even say thank you enough to everyone, to the Sickle Cell Warriors. Hey, you guys did an amazing job. You did amazing. for Shatara. That was her first time speaking, and she was calming me down. She's like, Mom, it's gonna be okay. I will not embarrass you. So she did a very good job. Shatara, thank you. Tamika, thank you. And Cheryl, my friend, thank you so much. I love you. All right.
Yeah, I'd like to say a couple words. Yeah, I really enjoyed today's talks because, you know, as you guys know, I'm always open to everything. And what I don't know, I always say, let me learn, let me look it up, let me refer to someone who might have more information. So this is great to have this community of other providers that know more that I don't to help our sickle cell warriors with their pain. Also, in order to continue this momentum, we would like to continue with educational events throughout the year. We used to do this every quarter, where we would meet different parts of the city and have an evening, an educational evening where families can meet together, have dinner, and learn something about something new or something that they just want to learn more about sickle cell. But obviously during this time of pandemic, it's something that we stopped doing. But now with this virtual platform, we can do this via Zoom. So I'd like to resume again next year. And what I would like is when you send in your comments or when you answer the the questionnaire, please comment what topics, what other topics you would like to hear about, or if you know of any speakers that you enjoyed listening to in other symposium, let us know so that we can approach them as well. Okay, and thank you for everybody for attending.
And one more thing before you close out. Again, we cannot do this without our sponsors, especially with this virtual platform. So we do encourage you again, when you leave here, if you can give us a little bit more of your time, and when you leave out of this session, go out to the main screen. It'll say exhibitors. Click in there, pick an exhibitor booth to go into. If you hit live, or I think it says watch now, you will have the opportunity to maybe speak to a couple of the vendors, not vendors, but exhibitors live. This is our first time having a webinar. There were some background glitches, but we look forward to in the upcoming year to really iron those out and bring more to you in the community. So again, thank you to all our speakers for all the days, and have a great evening, and please be safe. Talk to you soon. Bye.